perpetuating it and what's actually driving it. So I think that's really important in terms of getting really effective results. So the ones I'm going to go through today are stress, insulin resistance, coming off hormonal birth control, inflammation, and a few others. Cool, so defining PCOS. PCOS affects more than 1 in 10 women with a high incidence in Indigenous populations. So there's a lot of discrepancy in the estimates of the prevalence, I guess, anywhere from kind of 12 to 18% in Caucasian Australians and more like 22-23% in Indigenous Australians. So it's pretty high either way you look at it. PCOS is a metabolic syndrome of the endocrine system. So I'll explain what that means. Metabolic syndrome is really about your metabolism. It's about your blood sugars, your blood pressure. So many of you may know that incidence of diabetes and cardiovascular disease are higher in people with PCOS. So that's what kind of makes it a metabolic disease. It's also common to have high cholesterol and weight problems and obesity. The endocrine system just means all your hormones. So that's the system in the body that controls our hormones. So a syndrome means a collection of symptoms that consistently occur together and tend to influence one another. So I guess one point that I really want to get across in this talk is that PCOS is kind of an umbrella term and there's many different presentations of it. So often we have the typical idea of what PCOS is, and that tends to be a woman who's overweight, has acne, has hair growth on their face. And though women can present in this way, they can present in lots of different ways as well. So that's why I think it's so important to look at those drivers and what the factors are for you that's actually causing your symptoms. My other point there is PCOS is more correctly termed polyfollicular ovary syndrome. So if you've heard of ovarian cysts, that's very different from polycystic ovaries. So it's kind of a misnomer, though ovaries on the cyst is more common in women with PCOS, but it's not the same thing. So it's actually follicles on your ovaries, and we'll talk a little bit more about what that means as we go through testing. The cause is unclear. We don't really know what causes it as such. We know there's a lot of environmental and genetic factors that influence it. All right, so diagnosis. This is where it gets a little bit messy. Diagnosis is a huge issue in PCOS at the moment, and like I mentioned before, that big research centre coming together to define the guidelines for treating PCOS was because there was so many different ideas of what diagnosis meant. So many people were getting diagnosed in different ways. That's why they came together and decided we need to sort this out. So there's 3 different diagnostic criteria, and they're all varying combinations of the following. So we'll first go through these points at the top. So the first big one is hyperandrogenism, which means high androgens. So the androgen you'd probably know best is testosterone. We can assess this either clinically, so that's in clinical practice, and that's by seeing hirsutism, which is male pattern hair growth. That often presents for women around the face, on the chin, the nipples, sometimes some chest and back hair. Acne is really common. So acne is in about a third of women with PCOS, and about 70% of women with PCOS have the hirsutism, so that male pattern hair growth. The other one, which is a little less common but still happens, is the male pattern alopecia. So that's where you start to lose hair from your head, either receding, like in a kind of male pattern, or just an overall thinning of the hair, or feeling like your hair's just falling out more than it should be. The other way to assess hyperandrogenism is biochemically, so that's doing blood tests. Either of those are equally valid. The next point there is irregular menstrual cycles or lack of ovulation. So lack of ovulation is anovulation. I'll try not to use that word, but if I say anovulation, that's what it means, that you didn't ovulate. We'll go a bit more into what ovulation means in a second as well. Irregular menstrual cycles can be less than 8 menstrual cycles per year, or amenorrhea, which means not having a menstrual bleed for more than 4 months. So this presents really differently for a lot of people. Some women will kind of feel like they skipped a menstrual bleed. Some women will not have a bleed for 6 months. Some women will be regular, but it's every 6 weeks instead of every 4 weeks. And yeah, what makes it even more tricky is that some women still bleed every month, but they're not ovulating. So that's still polycystic ovarian syndrome. Polycystic ovaries on ultrasound is the last one there. And this one is a little bit in debate. So I'll talk a little bit about why. If you're under 25, it's very likely that you'll have polycystic ovaries on ultrasound. Estimates are that about 70% of young women have polycystic ovaries on ultrasound. So this doesn't mean that you have the syndrome. That's really important. So PCOS cannot be diagnosed simply by an ultrasound. So if we look at the criteria here, the NIH, which is the National Institute of Health, doesn't even include polycystic ovary morphology or polycystic ovaries on an ultrasound as part of their criteria. It's just about those first 2 points. The Rotterdam criteria includes all 3, and you just have to have 2 out of 3 of those. The AES, which is the Androgen Excess Society, says that you have to have the first one, so you have to have the hyperandrogenism, and then either one of the other 2. So, as you can see, this gives a lot of discrepancy on who gets diagnosed with PCOS or not. In fact, people who are included in the Rotterdam criteria, about 40% of those people will not be included in the NIH criteria. So it's really confusing for medical practitioners, but also obviously for patients. Another important point is here that all of these criteria include that all other conditions be excluded. So if you've only had an ultrasound and androgen testing, that's not enough to diagnose polycystic ovarian syndrome because it's a diagnosis of exclusion, which means you have to exclude everything else first to get a proper diagnosis. And this often gets missed. So we need to rule out anything more sinister, we need to rule out other causes, because if you start treating PCOS and it's something else that's causing your symptoms, you're not going to get any results. And those what's actually causing it is just going to get worse because it's not being treated. The other important point there is PCOS cannot be diagnosed while you're on the oral contraceptive pill or other forms of hormonal contraception. We'll go into that in a little bit too. All right, symptoms. So irregular periods, I already talked a little bit about, so less than 8 bleeds per year or no bleed for more than 4 months. PMS is common, that hirsutism, male pattern hair growth, and the hair loss, so the alopecia. Acne is very common, weight gain is common. In fact, women with PCOS tend to gain weight at about 3 kilos per year versus women without PCOS who gain weight at 1 kilo per year. So there's a huge difference, and that's when it comes back to PCOS being a metabolic syndrome. So that's about your metabolism being altered. Fertility issues, so if you're not ovulating, you can't conceive. This is definitely not the end of the world, and I think there's a lot of kind of scary fertility talk around PCOS. This is often very easy to manage, and there's some aspects of PCOS that actually make it easier to conceive. So don't stress too much about that. Anxiety and depression, this one's really big and often gets forgotten as well. Anxiety and depression is much more common in women with PCOS than women without. Also more common is eating disorders, including anorexia, binge eating disorder, orthorexia, so that obsession with health food, and bulimia. So we need to be looking out for those as well and knowing that it's much more common in women with PCOS. The last one there is signs of blood sugar imbalance. So that kind of comes back to it being a metabolic syndrome as well. So blood sugar imbalance we'll go a bit more into, but sugar cravings, fatigue, difficulty losing weight, they're all associated with blood sugar disbalance. All right, so this is just a quick table about how different symptoms tend to manifest for people over the lifespan. So often in childhood, there'll be some obesity or weight gain. Adolescence is when things really ramp up. Obviously, usually the hirsutism and acne, start getting irregular periods. You get older and you start having problems with infertility, gaining weight, trouble losing weight, and then into later years, diabetes and cardiovascular disease. This is a really common pattern for women with PCOS, and I guess the important thing is getting at it early, and prevention is really the best treatment. Especially, for example, with fertility. A lot of women with PCOS get to the reproductive years even 38, 40 years old, and they want to conceive now and they're not ovulating. So that's when it becomes an issue, and there's all this extra pressure because you're trying to have a baby, and it's much easier if you start addressing it in adolescence. You start getting regular ovulation, and then in reproductive years, fertility is a lot easier. All right, so let's talk about ovulation. I love hormones, so I hope no one gets too bored, but I really think it's important for everyone to understand their menstrual cycle, hormones a little bit better. So this is your menstrual cycle. Day 1 is the first day you bleed. And we can see at the top here all your hormones. It's a bit unclear, sorry about that. So like I was talking about before with the follicles, so polyfollicular ovary syndrome, these are your follicles. They start developing at the start of your cycle, and in each follicle there's a little egg. The egg is released during ovulation. In PCOS, we don't get to this point. So we just get all these primary follicles building up on our ovaries. And that's what you see on the ultrasound, is lots of little follicles that never matured and reached ovulation. So that's how we know that that person isn't ovulating every cycle.
Can I ask a quick question?
Yes.
Okay. Is that what the pill does? Stops that process there? Is that its aim generally?
Yeah, so on the pill you don't get any of this follicle development. Yeah, so hence it's hard to diagnose, or you're unable to really diagnose PCOS because you don't know if it basically cuts all your hormones down, so you just have a neutral hormones all the time rather than this cycling like this. So this is ovulation here. Really important here is luteinizing hormone, which is this one. I'll talk a little bit about that in testing. This can be really high in women with PCOS, and what's important is the ratio between this one, follicle stimulating hormone, and luteinizing hormone and follicle stimulating hormone down here. So we want a good ratio between the two, and that's often what's preventing ovulation in women with PCOS. It can also be insulin resistance, and high androgens stop that ovulation from occurring. So the problem with not ovulating is, so when we normally, this is a follicle that's matured and released its egg, ovulation has occurred. It then forms this little fella called the corpus luteum, which secretes progesterone. Now, progesterone is a girl's best friend. It's really fantastic. It makes our hair beautiful, our skin nice, it supports our mood, it's anti-anxiety, it supports our libido and sexual desire. So if you don't ovulate and you don't have this follicle here, you don't get a corpus luteum and you don't get this progesterone, which means you're just getting estrogen that's unopposed, I guess, and you don't have that hormone that does all those good things for us being produced at all. That's why mood disorders are more common in women with PCOS, and that's why we have skin issues and hair issues, or a big part of it anyway. Okay, I think that was all. So how do we know if we're ovulating? If sometimes women will still bleed even though they didn't ovulate, how do we know? So there's a few ways to assess it. One of my favourite ways is basal body temperature tracking. I'm not going to go into this too much because I don't have enough time, but basically it means taking your temperature as soon as you wake up every morning. Down here you see the chart. You can do this on apps such as Natural Cycles and Glow, or you can do it with a pen and paper. And this is the first half of your cycle. It tends to stay fairly low. You get a big temperature drop and then temperature rise, and that shows that you've ovulated. In the second half of the cycle, we see that the temperatures are higher, and that shows that progesterone is there, which is what we want. You can also get changes in your cervical mucus.